Hello, Anatomy and Physiology 1 students. This is the second part of the Cardiovascular System lecture on the heart. On this one, we're going to talk about the EKG, cardiac cycle, and cardiac output, and factors that affect those. Alright, so the first thing we're going to talk about is the EKG. So, you may hear it as an EKG or ECG, same thing. And what it stands for is electrocardiogram. So an electrocardiogram is a printout or a reading of heart activity. So what happens, you may have had an EKG done before on you. If you've ever gone to the emergency room, it's one of the things that they do. They what they do is they use up to about 12 electrodes, and they call those leads, L-E-A-D-S. Those are leads. And what it picks up on is the electrical current throughout the heart. Now, what it's done for, why would you do that, is to check for abnormal conduction of the heart or hypertrophy. And if the leads are picking up on the electrical activity of the heart, remember what we said in the first lecture about the excitation of the heart. So the electrical current running through the heart, think of the excitation of the heart, will get that heart to beat. Okay, so if we take a look at the electrical current running through the heart, which is easy for us to pick up, okay, we can look at these waves and segments of the waves on the readout, which is what you're seeing on those pictures, and that can reveal some problems. So it's a way that we can gain information about the electrical conduction of the heart and therefore how productive the heart is. There are three distinguishable waves. We have the P wave, the QRS wave complex, and then the T wave. So on the left picture, you notice that those waves are labeled. So this first little bump or wave, that's called the P wave. The QRS wave complex are the tips of the waves. This one would be Q, this one would be R, and this one would be S. Alright? And then this other large distinguishable wave is called the T wave. Those are our three waves. The three major waves. So what I want you to know, I want you to know, what is the P wave showing? What does that mean? So first of all, what is the P wave showing? It is well, we know that they're all, I guess we don't know that they're all showing electrical activity. But the P wave represents atrial depolarization. So depolarization of the atria. So during that electrical excitation, that action potential spreads from the SA node through the atria, and that's what you're seeing as this P wave. So we know now that as the electrical impulse travels throughout the atria, it's going to get that atria to do something. What is it? I hope you said contract. It's going to get those atria to contract. Very good. The second one, the QRS wave complex. That represents ventricular depolarization. Okay, when the ventricles depolarize. So we're going to imagine what's going on. The action potential spreading throughout the ventricles, and it's going to get those ventricles to do something. What is it? To contract. Very good. It's going to get those ventricles to contract. All right, the T wave. The T wave is ventricular repolarization. Okay, it's repolarization. That's going to remind you of the graph that we saw on the action potential, on the phases of the action potential. You learned about repolarization there. And this is when the ventricles repolarize. So the inside of the plasma membranes, okay, are becoming more and more negative. Okay, that is a change in electrical current. And so that is going to be picked up by those leads. And we're going to see it as a wave, represented as a wave on the EKG. So ventricular repolarization, which is shown on the T wave, this is going to occur right before the ventricles begin to relax. So those three waves, so we have atrial depolarization, ventricular depolarization, and then ventricular repolarization. You might ask yourself, well, wait a minute. The atria depolarized, they should be repolarizing as well. They are. However, where they're going to repolarize, or when they're going to repolarize, is about right here. Okay? This is at the same time the ventricles are depolarizing. So, it's masked. It's masked by the QRS wave complex. Okay, so I would like you to be able to recognize what a normal EKG looks like. These particular pictures that I have on your PowerPoint. And be able to explain those three distinguishable waves. Okay, the next we're going to talk about the cardiac cycle. So what is the cardiac cycle? It is all the events associated with one heartbeat. During the cardiac cycle, the two atria contract, so they're in atrial systole, while the two ventricles relax, they'll be in ventricular diastole. Then, while the two ventricles contract, systole, the two atria relax, which is in atrial diastole. Now, the cardiac cycle describes pressure and volume changes taking place in the heart. You can also overlay the electrical activity that's occurring in the heart, because the electrical activity is what brings about the contracting. Okay? And the contracting, when the heart contracts, it squeezes on that blood, which changes the pressure, okay, which in turn changes the volume. So I have a short animation for you to watch about the cardiac cycle. End the show, and here we go.
This animation illustrates a single cardiac cycle, starting with the right side of the heart. In reality, of course, the two sides of the heart work together at the same time, but it is easier to understand if we look at them separately, because each side of the heart has a different function. The cardiac cycle begins as deoxygenated blood flows from the body into the right atrium via the superior vena cava and inferior vena cava. In the next phase of the cycle, the right atrium contracts, pumping blood into the right ventricle through the tricuspid valve. Once the right ventricle fills with blood, the tricuspid valve closes to prevent blood flowing back into the atrium. The right ventricle contracts, forcing the pulmonary valve to open as blood is pumped into the pulmonary artery. Blood then travels to the lungs and the pulmonary valve closes. At the same time, the right atrium relaxes, ready to accept the next intake of blood. In the lungs, the blood picks up oxygen and releases carbon dioxide. Oxygenated blood flows from the lungs into the left atrium via the pulmonary veins. The left atrium contracts to pump blood into the left ventricle through the mitral valve. Once the left ventricle has filled with blood, the mitral valve closes. Next, the left ventricle contracts, forcing the aortic valve to open, allowing blood to be pumped into the aorta and from there around the body. The aortic valve closes to prevent blood flowing back into the left ventricle, and the left ventricle relaxes, ready to accept the next intake of blood. Cardiac cycle is now complete.
Penn Station's all about good taste.
All right, so one thing that I hope that you saw from your takeaway from the animation was that when the heart contracts and it creates that pressure around the blood, creates a pressure which in turn opens up those heart valves, okay, and helps to move that blood through. So it's also the pressure changes. The pressure change is going to cause volume changes there in the heart. Okay, the next concept that I want to talk about is cardiac output. So, what is cardiac output? It is the amount of blood pumped out by each ventricle in 1 minute. So, what goes into this cardiac output? There's a few things. It's actually the product of what we call stroke volume and heart rate. So stroke volume, you can think of that like how much it pumps, and the heart rate as how fast it pumps. So if you look at the picture that I have here on your PowerPoint slide, the cardiac output is a volume, okay? So it's mils of blood per minute. And what are the factors that go into it? It is the stroke volume times the heart rate. So stroke volume times the heart rate will give you cardiac output. Give you your cardiac output. Now heart rate. Heart rate we know is going to be increasing or decreasing. That one's not too involved. However, stroke volume is. So now I want to talk a little bit about stroke volume. So what exactly is stroke volume? It is the full load of blood before it gets pumped out. So the full load of blood in the heart before it gets pumped out. There are 3 main factors that affect stroke volume. That's what we're going to talk about now. The first one is called preload. Preload is how much the ventricles stretch to hold the blood before contraction. So how much blood is actually going into that ventricle before it contracts. Now, there are factors that can increase preload and factors that can decrease preload. So first of all, factors that increase. One factor is exercise. So if we're exercising, or we're increasing our circulation, and we're bringing that blood very quickly back to the heart, okay, that is going to increase our preload, the amount of blood that goes into that ventricle. Another one is slow heartbeat. So slow heartbeat, you might think, well, that doesn't really sound right because you just told me exercise. And I know that when we exercise, our heartbeat goes really fast, but why is it slow heartbeat? Okay, let's think. In a regular heartbeat, so the lub-dubs. So regular heartbeat, lub-dub, 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 lub-dub. Let's slow it down a bit. Lub-dub, 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 lub-dub. We've slowed down that heartbeat. If we can imagine what's going on, right? Blood is going into the right atria, if we're contracting that blood, going into the right atria, down to the right ventricle, and because it has slowed down, it gives it more time to load in the blood, and therefore more blood in there, and that means more preload. So factor that will decrease, and I'm going to give you one, and hopefully it's an easy one to remember, and that's going to be blood loss. This one's easy to remember because if we lose some of our total blood volume, we have less blood. Less blood being pumped back, okay, into the heart, therefore the ventricle, and it's going to decrease our preload. So overall, if we increase our preload, it's going to increase our stroke volume, okay? If we decrease our preload, it will decrease our stroke volume. Another factor is contractility. So there's that word again, ability to contract. So it's how much the heart muscle can contract, that myocardium. So therefore squeeze. Now when our heart contracts, we know it's squeezing that blood. It's creating the pressure. It's creating the pressure that will now be in the blood. It doesn't make any sense. And the heart contracts, it squeezes around the blood and creates the blood pressure. That's much better. Now, how hard the heart contracts is directly related to calcium ions. So we do know if you increase calcium ions directly around that heart, you're going to increase contractility, how much that heart can contract, how hard it squeezes. So factors that increase these calcium ions. But some other molecules can do it as well. Glucagon will do it. Thyroxine. Epinephrine. Another name for epinephrine is adrenaline. And sometimes, if the heart is just not contracting enough, in emergency medicine, a shot of epinephrine or adrenaline are right around the heart. It's going to get the heart to contract really hard. There's another type of medicine, it's called digitalis. That's going to get the heart to contract even harder. So these are going to increase the contractility. If we increase the contractility, what does that do to the stroke volume? It's going to increase the stroke volume. All right, factors that decrease: in excess of hydrogen ions, excess potassium ions, and calcium channel blockers. Now there's medicines out there that are deemed to be calcium channel blockers. Now this should make sense, because if calcium, excess calcium, a lot of calcium around the heart is going to get it to contract really hard. If we can block the calcium, then it's not going to contract as hard. So it's going to decrease contractility. If we decrease contractility, then we're going to lower the stroke volume. Some people are given calcium channel blockers if they have high blood pressure, for example. It kind of depends on the situation of the patient. But let's think about that. If they have high blood pressure that's caused from the heart contracting really hard, right, and creating that blood pressure, then if we can get the heart to back off of that and not create as much pressure, then we're decreasing that overall blood pressure. Okay? All right, next factor. It's called afterload. Afterload is the back pressure created by the newly ejected blood, the blood that is now in the artery. So if we're tracking the blood through the heart, so for example, let's say we've tracked the blood through the heart and it went into the left atria and down to the left ventricle, and then the left ventricle contracted and created pressure, opened up the semilunar valve, and all that blood, almost all that blood, went into the aorta. Okay? Now, that newly ejected blood that is now there in the aorta, it had to move blood that was already there. right? Because at no time is it ever going to be empty. So there's always going to be newly ejected blood there. And so it had to move that blood to a different part in the blood vessel. So that is the afterload. It's the back pressure created by the newly ejected blood. So factors that increase. One factor that's going to increase afterload is vascular resistance. So if you have high vascular resistance in the arteries, then that's going to increase the afterload. So here's the thing. This factor, if you increase afterload, you're going to decrease your stroke volume, the amount of blood that got moved. So I'm going to say that again. If you increase afterload, you're going to decrease your stroke volume. If you decrease your afterload, you can increase your stroke volume. One factor that will decrease afterload is a decreased blood pressure. Decreased blood pressure, that's going to decrease our afterload. If we decrease our afterload, that's going to increase our stroke volume. All right, so we're going to practice with some questions. So what I'm envisioning is in your notes, write out 1 through 5, and I want you to practice answering these. So number 1, if the heart rate increases and the stroke volume stays the same, what does this do to the cardiac output? Okay, let's imagine that equation that I gave you earlier. So the cardiac output equals stroke volume times heart rate. So if the heart rate increases and stroke volume stays the same, what does it do to the cardiac output? What would it do to that volume number? It's going to increase it. Very good. Now for the rest of these questions, let's assume that the heart rate stays the same in the body. Of course, we know it doesn't work that way. Our body will adjust the heart rate to help adjust the stroke volume. Oh, no, scratch that. Our body will adjust the heart rate when factors affect the stroke volume, and because we're going to try to even out, our bodies try to even out that cardiac output. But for these questions, in order to understand the factors that affect stroke volume, I want you to assume that the heart rate stays the same. Okay? So what happens to cardiac output if heart rate stays the same and the stroke volume decreases? So the cardiac output will also decrease. Hope you got that right. Okay, number 3. If contractility decreases, what does it do to the stroke volume? Contractility decreases. What does it do to the stroke volume? It's going to decrease the stroke volume. Okay, what is it doing to the cardiac output? It's going to decrease cardiac output. Very good. Okay, number 4. If preload increases, what does that do to the stroke volume? It's going to increase it. What is it doing to the cardiac output? It's going to increase it. All right. So number 5. If afterload increases, what does that do to the stroke volume? It's going to decrease stroke volume. Okay, what's it going to do to cardiac output? It's going to decrease cardiac output. All right, so I hope that you got those correct. All right, this is the end of our lecture. So this is the end of what we're going to be talking about the heart for the most part. Your next lecture is going to be on the blood vessels. So we're going to be talking about the blood vessels. We're going to go into more detail about the vascular resistance and all that fun stuff. So look forward to your next lecture, and it'll be on vessels. Thanks for listening, and I hope everybody is happy and healthy.